headache and why do we call it cluster? Cluster, you might be knowing the meaning of cluster, that is a group. Actually, these headaches, these come in clusters. Like patient is having headaches for maybe few weeks or few months, and then there comes a period of remission, which should be at least 1 month or more than 1 month. This is when we call them episodic cluster headaches. So let's start with the symptoms. And cluster headache, it is characterized by a unilateral severe headache, which is a hot poker or stabbing pain, and the area is around the eye and the temporal region. It may involve the pain around the one eye with drooping of the lid, tearing and congestion on the same side as the pain. It is very severe, excruciating type of headache with autonomic dysfunction, as I've already told you, lacrimation, rhinorrhea, nasal congestion, conjunctival injection, these are all can be associated. Not necessary for all of these features to be present, but some of these may be present and some may not be present in any patient. Patients are usually agitated and restless, not like migraine in which they tend to sit calmly in a dark environment. These patients, they are agitated, they are restless. And the duration of the headache is 15 minutes to 3 hours, 15 minutes to 180 minutes, you can say. This picture is showing again the cluster headache clinical presentation. These are typically, they can be nocturnal, that is nocturnal awakening is typically associated with cluster headache because the pathophysiology involves hypothalamic dysfunction. Average frequency 1 to 3 in 24 hours and lasting 15 minutes to 3 hours. You can see in this picture there is temporal artery bulging and pulsating, severe headache, pain behind the eye, unilateral ptosis, swelling and redness of the eyelid is present, and there is a smaller pupil as compared to this side, to the normal side. There's conjunctival injection, there is lacrimation or tearing, nasal congestion or rhinorrhea can be present, and flushing of side of the face and sweating. So it's not necessary for all of these symptoms to be present in one patient. Some patients may have 1 or 2 to 3 and some may have other. So you need to think about cluster headache when patient presents with nocturnal headaches and excruciating severe headache. The area is very typical around the eye, periorbital and temporal region. And the duration is very important again, 15 minutes to 3 hours, and these are the multiple times in a day. Now this is what I was talking about. Cluster headaches can be episodic or these can be chronic. We call them episodic when there is a cluster of headache period for about weeks to months, and then there is pain-free remission period, and which is about a month or more, and which lasts from 7 days to 1 year when untreated. 2 cluster periods lasting 7 days to 1 year. When it becomes more than 1 year of headaches without any remission, we call it chronic cluster headache. Chronic cluster is exactly the same, but it's occurring without a remission period for 1 year or more than 1 year, or with remissions which are lasting less than 1 month. It's not necessary to remember this, but just to clarify things that we have 2 types of cluster headache. One is episodic and one is chronic. Now, how to treat the cluster headache? First of all, there is acute or abortive treatment, which include oxygen inhalation, 100% oxygen by mask or 8 liters per minute, and subcutaneous triptans can work as an acute or abortive therapy of cluster headache. Then we have chronic and preventive therapy, because these headaches will keep on occurring unless we don't give any preventive treatment. And the preventive treatment include calcium channel blocker, that is verapamil. Lithium has been used as a prophylaxis, oral steroids, which are used short term, like we start with 40 to 60 milligram per day, and we gradually taper it off over the next 10 to 15 days. So this is also a form of preventive therapy, but we don't use long-term steroids. And melatonin has also been used, and other drugs which are used for prophylactic therapy for cluster headache include valproate and topiramate. Now, second is paroxysmal hemicrania. This is Headache characterized by frequent, that is more than 5 attacks per day. It is unilateral, severe, short-lasting. Now please concentrate on the duration. This is 2 minutes to 30 minutes headache. This is not 15 to 180 like cluster, and it can also be associated with autonomic phenomena like lacrimation and nasal congestion. And in these headaches, indomethacin is the treatment of choice. Indomethacin is in a way diagnostic and as well as therapeutic. The headache is responding to indomethacin and it is fulfilling the other characteristic, which is paroxysmal hemicrania. Now these are some features of paroxysmal hemicrania. It is more common in females and the ratio to female to male is 2:1. Attack frequency can be 5 or more per day. Duration is 2 minutes to 30 minutes. Response to indomethacin that is required for diagnosis, as I have told you, response to indomethacin is diagnostic as well as therapeutic. Conjunctival injection or lacrimation, patient should have any one of these. Nasal congestion or rhinorrhea, patient should have any one of these. Eyelid edema is usually present. Forehead or facial sweating, at least one of these has to be present. And Horner syndrome can be present in restlessness and agitation. There is no restlessness or agitation in these patients. Then features of SUNC. This is another kind of trigeminal autonomic cephalagia, and again there are certain overlapping features, but you need to differentiate these headaches from each other. But as I've already told you, this is little beyond the scope of fourth year students, but just for the sake of description that you should know about these terminologies and these headaches. Now this headache is very short lasting. The duration is in seconds to minutes. It can last up to 5 seconds to 4 minutes, and the attack frequency can be in hundreds. It can be from 3 attacks per day to 200 attacks per day. And there is no response to indomethacin. Conjunctival congestion, lacrimation can both be present. Nasal congestion, rhinorrhea is usually not present. No eyelid edema, no forehead sweating, no hardness, and no restless or agitation is present. So this is easier to remember. Very short-lasting headache, not responding to indomethacin, and only associated with conjunctival congestion and lacrimation, and none of these last 5 features. And there can be 3 to 200 attacks per day, as these are very short-lived. Treatment is lamotrigine as a prophylactic therapy, and topiramate also works in some patients. Now we start with the secondary headaches. Now the secondary headaches, these are usually due to systemic or exogenous disorders. The management of secondary headache focuses on the diagnosis and treatment of the underlying condition. Secondary headaches can be caused by medication related, like medication overuse headache. These can be post-traumatic. These can be due to disorders of intracranial pressure, either raised intracranial pressure or low intracranial pressure. These can be structural, like tumors. There can be cranial neuralgias. There can be vascular, like temporal arteritis. Causes can be infections, like meningitis and encephalitis, and causes even can be metabolic. Now this is sort of revision about history of headache, and taking a good history is very important as far as the diagnosis and the workup and the differential diagnosis of the headache patient is concerned. History should include the location of the headache, whether it is frontal, occipital, around the eye, periorbital, temporal. Severity is very important, either it is mild, moderate, severe. Character is very important, either it is a constant headache, it's a jabs-like pain, or it is a throbbing headache. Then associated symptoms are very important, like you can characterize whether it is a primary or it is a secondary headache. Nausea, photophobia, phonophobia, these are all features of usually migraine patients. So associated symptoms are important. Then we have associated symptoms other, as I have mentioned, the cranial autonomic symptoms. These will help you in categorizing whether the headache is primary or secondary. So this applies to both. You have to categorize first whether the headache is secondary or primary, and you will not know, the patient will not tell you that I have a secondary headache. You have to dig out through a proper history and examination whether the headache falls in the category of primary headache or secondary. Now the presence of autonomic symptom like lacrimation or ptosis, relieving and exacerbating features like effect of posture, whether it is worsening with standing up, that is characteristic of low CSF pressure headaches, and whether it is worsening with coughing, bending forward, that can be due to raised ICP. Then patterns, age at onset, young onset, usually primary, episodic, longer history, prolonged episodic headaches, mostly these are primary headache disorders, frequency of the headache, any previous history of similar headaches, then duration of headache episode again characterizes between different sort of headaches. At the migraine headaches, they have a duration of 4 to 72 hours. Tension headaches, they can last from days to up to a week. And then we discuss different type of trigeminal autonomic cephalagias, which can last from minutes, seconds, and hours. And then the triggering factors. As you all know, there are certain triggering factors for certain headaches, like migraine is triggered by certain foods and lack of sleep or excessive sleep and stress, dehydration, and many other things. Then we have secondary headaches, which can be like headache secondary to raised ICP. These can be triggered by coughing or bending forward or Valsalva maneuver, whichever maneuver is causing a rise in the intracranial pressure. And lower CSF pressure headache, they worsen with standing up. Then pattern of analgesic use, that is important to ask because you should also know whether the patient is having medication overuse headache, excessive use of analgesics, either simple or the non-steroidal anti-inflammatory drugs can cause medication overuse headache. Then family history of headache, family history mostly is found in migraine headaches. Then you have red flag symptoms like fever. Fever may indicate meningitis, encephalitis, or sinusitis. Sudden onset and less than 1 minute peaks in less than 1 minute and severe headache, that is thunderclap headache. It may indicate subarachnoid hemorrhage or any other underlying serious pathology, or it can be simple primary thunderclap headache that I described in the previous lecture that we call Fleming syndrome also, and that is due to spasm of the intracranial vessels. The features of raised ICP I have been repeatedly describing: headache, vomiting, and Cushing reflex, that is bradycardia, hypertension, and patient may have epiledema. Patient may have false localizing signs like unilateral or bilateral six-nerve palsies. Then comes jaw claudication, that is a feature of giant cell arteritis or temporal arteritis. What is jaw claudication? The patient, when they start chewing food, they start having pain in the jaw as they chew more and more because there is a ischemia of the jaw muscles, and that is a part of giant cell arteritis. Now look for what? History is finished. Now comes the examination. Fundoscopy, you need to look for papilledema and cranial nerve. You need to look for any cranial nerve involvement, sixth or any other. Giant cell arteritis, you need to look for loss of pulsatility of the temporal vessels and tenderness on temporal vessels. In meningitis, you need to check the temperature, look for the signs of meningeal irritation, and overall you need to examine the patient for any focal motor deficit. It may indicate any structural lesion or maybe some infective lesion like abscess. They may have monoparesis, paraparesis, depending on the underlying pathology. Test for what? Again, now when you take a proper history and when you do a good examination of your patient, there are certain differential diagnoses which come to your mind, and your workup and the test will depend on that differential diagnosis, and you will start your workup on the basis of your history and examination. For example, if you are suspecting that a patient he is older age group, like more than 50 years old, and you're suspecting giant cell arteritis or GCA, you will first proceed for a complete blood count, ESR, CRP, to look for the inflammatory markers, and if these are suggested, then you will proceed for temporal artery biopsy. And if you are slightly in doubt that it may be due to some other cause or some intracranial pathology, then you can even go for a CT brain or maybe MRI if there is some differential in your mind to rule it out. The neuroimaging, for most of the secondary causes, we need neuroimaging. It may be CT, it may be MRI, depending on the differentials and depending on the findings from the CT. Then we have CSF studies, which can help in many patients, including CNS infections and also in subarachnoid hemorrhage, especially when the CT is normal. Then intraocular pressure. Headaches can occur in glaucoma as well. So in the slightly older age group, you need to keep in mind that even the ophthalmological problems like glaucoma can cause headache, and you need to rule it out by referring to the ophthalmologist for measuring the intraocular pressure. Now this is a mnemonic of SNOOP. This is review of the clinical feature for organic origin, that is secondary causes of headache. For S come the systemic symptoms, that is fever, weight loss, or secondary risk factors like history of malignancy or HIV, or risk factors for HIV, or there is any organ transplant and patient is on immunosuppressive drugs. And then come the neurological symptoms, which include confusion, impaired alertness or consciousness. Again, it's a red flag. Onset, sudden, abrupt, or split seconds. Again, most probably secondary headache. Older age group, new onset and progressive, especially in the middle age, that's more than 50 years. Think about either giant cell arteritis, ischemia, or any cervical disease. Previous headache history, patient has previous history of headache, or if there is first headache or different headache, then that has to be taken very seriously. Patient may have migraine in the past, but now he has come to you with a sudden severe headache which is different from the previous headache. So you need to take it into consideration and you need workup for secondary headaches. Then come the red flags. So what are the points that we considered as red flags when a patient presents with headache? New headache, especially in over 50 years, abrupt onset and unusually severe. Change in usual headache pattern. As I have told you, patient with tension type headache and migraine headache and other cluster headache, they are not immune to any other secondary headache problems. They are not immune to any other disease. So if there is a change in the usual headache pattern, it warrants a proper workup. Headache associated with focal neurological findings. Again, I don't know, so many students are confused in focal neurological findings. Any cranial nerve palsy, any motor deficit, or extensor planters, these are all focal neurological findings. The findings of raised ICP like papilledema, again, it's a red flag. Altered consciousness, personality changes, lethargy, seizures, again, red flags. Fever, neck stiffness points towards meningitis. Systemic signs and symptoms, again, either vasculitis or some infective causes, and then temporal artery tenderness points towards giant cell arteritis. Okay, now indications for neuroimaging in patients with headache symptoms. All patients with headache, they don't need neuroimaging. Like if you're very much confident that the patient is having tension type headache or migraine headache, there's no need to go for neuroimaging, neither CT nor MRI. When you find focal neurological findings, then the headache starts after exertion or Valsalva's maneuver, as I've already explained. It means there is some underlying increased ICP. Acute onset of severe headache awakening the patient at night, change in the well-established headache pattern. Previously, he used to have headaches, but suddenly there is a change. The intensity has changed. It has become more severe. It is awakening him up from the sleep. It is early morning associated with vomiting or any other symptoms. That is change in the well-established headache pattern. That is also a red flag which indicates the need of neuroimaging. Then comes new onset headache in patients more than 30. This is more than 50 years actually. Sorry for the mistake. This is more than 50 years. New onset headache in patient more than 50 years. New onset headache in patient with HIV infection or previously diagnosed malignancy, or in those patients who are immunosuppressed because of any cause. May it be intake of steroids or other immunosuppressive agents, or maybe he's taking immunosuppressant agents for like organ transplant. After organ transplantation, patients are usually kept on long-term immunosuppressants. So those patients also, they are prone to develop certain infections, and they need to work up for secondary headache. Now, reasons to consider lumbar puncture to evaluate headache. Lumbar puncture is not done in each and every patient in whom you are suspecting had some underlying pathology. There are certain indications. If there is a first or worst headache and you are suspecting subarachnoid hemorrhage or meningitis, lumbar puncture might help. In subarachnoid hemorrhage, if your CT is not showing any abnormality, if the patient is late, has presented late to you, especially when they present late, CT findings start disappearing, then the lumbar puncture can help you. CSF findings can help you. Meningitis, of course, acute or chronic, CSF is definitely diagnosis, or what I say, the investigations of choice, and the different CSF studies will lead to the exact diagnosis. Then headache with fever or other symptoms or signs suggesting infection. Again, we will be suspecting meningitis or maybe encephalitis. Meningitis can be acute, can be chronic. Again, CSF studies are needed. Then subacute or progressive headache in a patient with risk factors. Risk factors may or may not be, because chronic meningitis is caused by TB as well, TB meningitis, which can occur in immunocompetent patients, not necessary for the patient to be immunocompromised. But we have fungal meningitis, that is cryptococcal meningitis, which usually occurs in immunocompromised patients, either HIV or immunosuppressed due to any other cause. Then leptomeningeal mats or carcinomatous meningitis in those patients who have history of primary malignancy. And then pseudotumor cerebri or idiopathic intracranial hypertension, which we call it now, is an old name, pseudotumor cerebri. There is no tumor in the brain, but this is just an old name for idiopathic intracranial hypertension. In obese females with papilledema, and orthostatic headache with diffuse diurnal enhancement on MRI, which is a low CSF pressure syndrome, and I'll describe it later. Okay, thunderclap headache, as I have already told you, the term thunderclap headache is used to describe a severe sudden headache of instantaneous onset with peaks in 1 minute at the most. And there are different causes of thunderclap headache. On top is subarachnoid hemorrhage, and then we have lots of other causes of thunderclap headache, like cerebral venous thrombosis, like carotid or vertebral artery dissection, diffuse cerebral vasospasm, that is the primary thunderclap headache, which we call Fleming syndrome as well. Accelerated hypertension or PRAS, that is posterior reversible encephalopathy syndrome, which occurs in hypertension, and when the accelerated hypertension is associated with certain MRI findings, radiological findings, then we call it PRAS. If it is without us, then this is simply accelerated hypertension. Pituitary apoplexy, when there is hemorrhage in a pituitary adenoma, it can also cause thunderclap headache, and it can give rise to various findings like various cranial nerve abnormalities, and altered consciousness can also occur. Patient can develop renal crisis, they can go in shock, and they can develop hypoglycemia. Then we have cocaine and adrenergically active drugs like amphetamine. These can also cause thunderclap headache. Migraine sometimes can present as thunderclap headache. Sometimes, it's very rare. It's not usually thought of as a cause of thunderclap headache. Meningitis sometimes, not very commonly. The spontaneous intracranial hypertension, not very common cause of thunderclap headache, but it can. Another cause is intracerebral hemorrhage. Simple intracerebral hemorrhage, which can be hypertensive or non-hypertensive hemorrhages. These can also present as thunderclap headache. Now, subarachnoid hemorrhage, 50% patient, they have sentinel bleed. Sentinel bleed is a warning bleed in which there is slight leakage from the aneurysm, and the patients, they have sudden severe headache, but their imaging is normal, but this is a warning sign. They will usually rebleed within 2 to 6 weeks. So if you have high suspicion, any patient who has a normal CT but who has a typical sudden severe headache, you should go for angiogram or further workup as advised by the neurosurgeon. Then rebleed has a 50% mortality, and more than 50% rebleed in established subarachnoid hemorrhage. They may have 50% mortality, and more than 50% of survivors have significant neurological deficits. Subarachnoid hemorrhage has to be taken very seriously. And in head CT can be negative in 1 to 10% of the cases, and the sensitivity of plain CT decreases with the time from onset of symptoms. And you need to do CSF studies like LP. If head CT is negative, you will get RBCs there and xanthochromia. After 3 hours, RBCs will start appearing in the CSF, and xanthochromia will appear after 12 hours. And you need to get angiography done, either it is a CT angiogram, or if required, then you can go for digital subtraction angiography, that is DSA, before basal angiogram, if you get positive CT, or if CT is negative, LP is positive. In any case, you need to go for angiogram to detect any aneurysm or AV malformation which has led to the subarachnoid hemorrhage, because the treatment of that aneurysm or AV malformation is mandatory. Otherwise, there is always a chance of early rebleed in these patients, and in rebleed mortality is 50%. This is a CT scan which is showing very typical subarachnoid hemorrhage, showing this hyperdense signals in the subarachnoid space around this brain stem, and in the Sylvian fissure you can see. This is a CT of subarachnoid hemorrhage. Now, this is description of how sensitive is CT scan when a patient has subarachnoid hemorrhage and when he presents to you. If it is on the very first day, this is day 0, we take it day 0. the probability of finding CT abnormalities is 95%. Still, there is 5% chance of missing the subarachnoid hemorrhage. In that case, you need to go for LP in these patients. On day 3, 74%, so LP is 100% needed. In all the cases, if patient comes to you on day 3 or maybe day 7, history is suggestive, CT is normal, you need to proceed with LP. 2 weeks, the sensitivity is 30%, and 3 weeks is almost 0%. If a patient has subarachnoid hemorrhage and he presents to you after 3 weeks, you will not find anything in the CT, and even CSF may not help you because the abnormalities, they persist for up to 2 weeks, and after that CSF abnormalities also start to disappear. In that case, you may consider angiography directly, or you can consult a neurosurgeon. Then comes cerebral venous thrombosis. It can also present with thunderclap headache, and but headache can be moderate, can be severe and throbbing. It can be thunderclap, it can be simple, moderate to severe headache. Patient may have nausea, vomiting, photophobia, and they can have papilledema, signs of raised intracranial pressure. CT can show you a dense clot sign. As you can see in this picture, this is dense clot sign in the sinus, superior, sagittal, and transverse. And involved dural venous sinus show filling defect on MRV or CT venogram. Now this is MRV brain, which is showing filling defect in the superior sagittal sinus. And this is a CT brain, which is showing a hemorrhagic infarction. And patient had history of OCP intake, she was a female. So history also gives you clues regarding the underlying diagnosis, as I've always been stressing on it, that good history and a good neurological examination is a cornerstone of your diagnosis. Then comes temporal arteritis. Temporal arteritis or giant cell arteritis, which is large vasculitis. It is rare before the age of 50 years. Temporal artery tenderness, palpable temporal artery, erythematous artery, or nodular temporal artery. These all indicates probable temporal arteritis. Patient may have visual disturbance, and if it is left untreated, 7 to 60% can have. Patients may develop vision loss. Jaw claudication, I've already described. Systemic symptoms, they may also have systemic symptoms like fever, weight loss, loss of appetite, and malaise. And many of these patients of temporal arteritis, they have associated symptoms of polymyalgia rheumatica. Polymyalgia rheumatica is a rheumatological condition which is characterized by proximal muscle pain, tenderness, and stiffness. These patients, they have ESR usually more than 50 millimeter per first hour. They have raised CRPs. They may have anemia on the complete blood count, and temporal artery biopsy can be taken, which may show multinucleated joint cells and inflammation, but this biopsy is again 50% sensitive. It may miss the lesions because there are skip lesions, so the site of the temporal artery biopsy also counts from where the biopsy is taken, and it may not be the involved area. So when your suspicion is high, the history is suggestive, the inflammatory markers are raised, sometimes your temporal artery biopsy even can be negative, but then you have to start the patient on treatment after you rule out any other possible causes. If you're thinking about any infection, go for CSF studies. If you're thinking about some structural problem, you may go for a neuroimaging, and after that, you can start the patient on high dose steroids, which are usually continued for at least 2 years. Meningitis patients, they have acute severe headache with a stiff neck and fever, and there is striking accentuation of the pain on eye movement. They may be photophobic, may be mistaken for migraine, and that the cardinal symptom of pounding headache and photophobia, nausea, vomiting, these are present. But as I have told you, migraine has its own presentation, and it is usually not like if a patient comes to you first time with acute severe headache. It is very, very unusual to diagnose your patient as migraine. Always think about secondary causes. Then there is intracranial hemorrhage, and patient may have acute severe headache with stiff neck but without fever, and it can be due to a ruptured aneurysm or maybe an AVM or intraparenchymal hemorrhage due to hypertension. Simple hypertension can also cause intraparenchymal hemorrhage, and hemorrhage due to hypertension, the most common sites are basal ganglia, that is the putamen and the thalamus and pons and cerebellum. These are the typical sites for hypertensive hemorrhages, and if hemorrhages are is present in any lobe, then it is either frontal lobe, temporal lobe, occipital lobe. It's usually not secondary to hypertension. It needs workup with angiogram or any other studies. Then comes brain tumor. The pain is usually nondescript. It's a non-specific kind of pain and intermittent deep dull aching of moderate intensity. It is a misconception that brain tumor is always associated with headache. Headache may not be there even with large brain tumors. Slow growing tumors, if they don't cause the raised ICP and these are slow growing, they may not cause headache. It may worsen with exertion. If there is raised ICP, you may get these symptoms like worsening with exertion, change in the position with increasing pain, and they may have nausea, vomiting. Pain appears abruptly after bending, lifting, coughing. Now, what does it indicate? It means that the tumor is causing raised intracranial pressure. That's why after these maneuvers, patient is complaining of worsening pain. Headache of brain tumor disturbs sleep in almost 10% of the patients. Now then we have trigeminal neuralgia. It is more of a facial pain than that of the headache, but it was mandatory to include it in secondary headaches. The fifth cranial nerve supplies sensation to the face and anterior half of the head. The motor part innervate the masseter, temporalis, and the pterygoids, and the trigeminal neuralgia is relatively common, mostly in older age patients and middle age patients. They are primarily affected in 60%. It is occurring in women. It is characterized by excruciating paroxysm of pain. Now remember, these are paroxysms of pain. These are electric shock-like sensations or pain which is occurring in the lips, gums, cheek, chin, and very rarely in the ophthalmic division. The second and third division of the fifth cranial nerve is mostly involved in trigeminal neuralgia, and the first division, that is the ophthalmic division, is rarely involved. The pain lasts for seconds to minutes. It is experienced as a jab severe enough that the patient winces. It occurs both day and night. It can occur several weeks at a time. And another characteristic is the presence of trigger zone. What is trigger zone? Like if the patient is chewing food, he will develop pain. Or if the patient is washing his face or shaving or cold air is blowing, so these can all cause triggering of the pain. Or if he touches certain part of the second or third division of the trigeminal nerve supply, it may trigger the pain. And this is very, very typical of trigeminal neuralgia. If the patient does not have any trigger zones, then you need to rethink about your diagnosis. An essential feature is that objective signs of sensory loss cannot be demonstrated, because usually trigeminal neuralgia does not have any underlying like structural causes. Mostly it is because of some vascular loop which is abutting against the trigeminal nerve or something like that. But the sensory loss is usually not demonstrated. If you objectively demonstrate a sensory loss over the face, then you should think about some structural underlying cause like dermoid cyst or any tumor. Treatment is with carbamazepine, which is the most effective drug in trigeminal neuralgia, works in most of the patients. We start with low dosage and we gradually increase the dose till we have control of the pain with least side effects. And baclofen and phenytoin can also be tried. Baclofen can even be combined with carbamazepine. Besides carbamazepine, we have oxcarbazepine, which can also be effective in patients, and pregabalin can also work. If drug treatment fails, then we have radio-frequency thermal rhizotomy, which is a thermal lesion or heat-induced lesion of the trigeminal nerve may be offered. And there is gamma knife surgery or cyber knife surgery can also be utilized if the patient is not responding to medical treatment. Then we have post-LP headache, most common complication following lumbar puncture, and up to 40% of patients they develop post-LP headache. It is most common in 18 to 30-year-old patients. It can last up to 5 days, and it presents with bilateral throbbing headache that worsens with upright position. It is thought to be due to persistent leak of CSF that exceeds its production. Treatment include rest, hydration, IV or oral, and if the patient is not responding to the conservative measure, and we have certain drugs like theophylline also, which can be used, and intake of caffeine can also help these headache. If the patient is not responding to any of these or all of these, and there is persistent headache, we can try blood patch. What is a blood patch? Blood patch is like, it is done by an anesthetist. What they do, that they draw, for example, you drew almost 5 cc CSF, and if patient is starting having headaches which are not responding to these conservative treatment, the anesthetist, they draw 5 cc of the blood and they inject that blood in the same site from where you drew the CSF, that is between L3 L4, is the usual site of lumbar puncture, and they inject it and that's it. It seals the leak inside and the pain usually subsides. Now this is spontaneous intracranial hypotension. The picture is actually, I need to show after the description. This is spontaneous intracranial hypotension syndrome. See, post-LP headache is also due to intracranial hypotension. But here there is no LP done. This is a spontaneous intracranial hypotension. They present when a patient is upright and is relieved when lying down. It is postural headache, same like we describe in post-LP headache, because the pathophysiology is same. When spontaneous intracranial hypotension persists, it becomes like a chronic belly headache without orthostatic feature. When it becomes chronic, it loses these orthostatic features, that it worsens with patient upright and relieves on lying down. It becomes like a chronic headache. There can be neck or interscapular pain which may precede the onset of headache, which is usually called hanger sign. An MRI may show gadolinium enhancement of the dura mater, or which we call as pachymeningeal enhancement. Cerebellar tonsillar descent may be there, or even the imaging can even be normal. When you do the LP, the opening pressure is less than 60 and it may be even negative. Normal pressure is 100 to 180 mm of water. CT myelogram may be more sensitive for determining the site of leak, and the most leaks occur in the spine, and these need neurosurgical repair. Now let me show you dural enhancement. This is dural enhancement or pachymeningeal enhancement in a patient with spontaneous intracranial hypotension. See, this is dura mater which is enhancing. This stentorial dura mater which is enhancing. And the leptomeninges, these are all fine. There is no leptomeningeal enhancement. Then we have idiopathic intracranial hypertension. It occurs due to reduced CSF resorption, and it usually occurs in younger, overweight female patients. Polycystic ovaries is one of the causes, and there are certain drugs which can cause this idiopathic intracranial hypertension, like tetracyclines and like the vitamin A supplements and vitamin A derivative like tretinoic acid, especially the oral tretinoin compounds which are used for acne treatment. These can be the cause. ICP is raised, the ventricle may be slit-like, may be normal, and in these patients we need to rule out dural venous sinus thrombosis. Why? Because many times the venous sinus thrombosis patients, they may not have any other abnormality on the CT like hemorrhagic infarction, and they may simply present with papilledema and headache. So in these patients we need to rule out dural venous thrombosis as a cause of the raised ICP before labeling them as idiopathic intracranial hypertension. Now what is the treatment? Remove or treat the underlying cause. Even hypothyroidism can cause intracranial hypertension. So if patient is hypothyroid, treat it. If the patient is taking certain drugs, OCPs, or vitamin A supplementations, or some sort of acne treatment which is including tretinoin compounds, you need to stop those. OCPs, you need to stop those. Need to repeat lumbar puncture. Patient may need repeated lumbar puncture as a part of decreasing the raised ICP, but that is not treatment of choice, because repeated lumbar puncture is an invasive procedure. It has its own side effect. Acetazolamide can be tried. It is a diuretic, and even thiazide diuretics can be tried as a measure to reduce the intracranial hypertension. If the patient is obese, first thing is to do weight reduction. If you are suspecting polycystic ovaries as a cause of weight gain, you need to investigate the patient for that, or you need to refer the patient to be investigated for that. And if you are suspecting metabolic syndrome or insulin resistance syndrome, either you should investigate or you should refer to an endocrinologist in these patients, because that can be a cause of obesity, and obesity can again lead to idiopathic intracranial hypertension. Then ventriculoperitoneal shunt insertion in those patients who are not responding to the conservative measures, and in whom after even removal of these risk factors, the patient still has persistent intracranial hypertension. The complication that is feared is vision loss. Prolonged papilledema will lead to optic atrophy and vision loss. That's why ventriculoperitoneal shunt can be used as a therapeutic option. Then we have certain other causes of secondary headache also. As I've told you, medication overuse headache. For that, history of medication overuse, detailed history is very important. What kind of medications they are using, what kind of pain medications, like simple pain medications like paracetamol or non-steroidal or opioid, these can all cause medication overuse headache if these are used in a prolonged period for more than 15 days in a month. And low CSF volume headache, due to repeated LVs, patient may develop low CSF volume headache. Obstructive sleep apnea, another cause of headache. Patients, they have disturbed sleep and they are sleepy in the morning. They are usually obese and they have early morning headache due to increased carbon dioxide or hypercarbia. And this is very much evident from the history of loud snoring, obesity, nocturnal arousals. So the diagnosis is not that difficult. In poorly controlled hypertensions, they may complain of headaches and post-traumatic headaches. There are many patients who developed headache after head trauma, and even head trauma can even trigger migraines. So you need to rule out if there is some contusion or even some subdural hematoma or any sort of CT abnormalities in these patients, because if the patient is having head trauma and complaining of headaches, CT is mandatory. When the CT is normal, then you treat conservatively as a migraine, or maybe sometimes with reassurance or simple analgesics, depends on the patient's presentation. So this is overall approach. Chief complaint is headache. First of all, you need to take a good history, not look for the headache alarms or the red flags as already described. If you are getting evidence of serious headache disorder by history or physical examination, then you need to work up to identify or exclude the secondary headache etiology. And if there is no such red flag, then diagnosis of primary headache disorder is made. Then you have to treat the primary headache. And if there is no diagnosis of primary headache, you cannot make it from the history. The headache is not fitting into any of the primary disorders. Again, you need to consider workup for secondary headache. So this was all about trigeminal autonomic cephalagias and secondary